Hey everybody, this is Dr. Ben Pearl with FitFoot U. So today we're going to be talking regenerative medicine and the future of medicine. So traditionally, a lot of pain clinics would really rely on things that mask the pain. And I'm here with Dr. Scott Martin. He is a regenerative medicine expert. He works very closely with Platinum Biologics and has his own clinic in both the pain management world and the aesthetics world, which is also part of regenerative medicine. Welcome, Dr. Martin.
Thank you very kindly. Appreciate the opportunity.
So there's been a lot of, I guess, news with regenerative medicine. A lot of people are excited about it. There's a lot of different directions people can go. You've got umbilical tissue, you've got placental tissue. Give us a little bit of a bird's eye overview. If I'm a patient or if I'm a doctor that doesn't know a lot about regenerative medicine, about how one can select a particular arm that they feel, when I say arm, I'm talking umbilical or let's say an amnion product that the patient or physician can feel comfortable with.
Well, I think there has been this general misinformation in the marketplace, and that's benefited, it's benefited a lot of people other than patients because there's this general feeling that stem cells are kind of like the, Harry Potter wizarding world, and we're just going to get stem cells and then magically things are going to be cured. And that's just simply not how this happens. I know that's how it's sold, and it's intentionally misleading to sell it that way. But I think the most important distinction should start with whether a patient is getting stem cells from progenitor stem cells, meaning pluripotent stem cells, or they're getting differentiated mesenchymal stem cells. Now, I'll make the distinction quick because I know we don't have all day, but pluripotent stem cells can turn into anything in the human body. Those have been illegal in the United States since George W. Bush was president, and they've been illegal for a reason. When you take a pluripotent stem cell that can turn into anything in the human body, I'm 52 years old. I am closer to the finish than I am to the beginning. And if I gave myself pluripotent stem cells, they have the ability to help the body heal at a cellular level, sure, but they also have the ability to feed oncogenes and tumor cells. And for this very reason, they've been illegal in the United States. Almost everyone remembers a sheep that was cloned back in kind of like 2008, 2010. That sheep's name was Dolly. Most people don't know that Dolly died of metastatic cancer. Dolly also had 5 baby sheep, and all 5 of her baby sheep died of metastatic cancer before 2 years of life. Dolly was cloned using pluripotent mesenchymal stem cells. Now, the only place in the world you can get those type stem cells are out of the country. You've got to go to Panama or Costa Rica or places like that for those cells. Completely illegal to be sold in the United States. What we're talking about here in the United States are differentiated mesenchymal stem cells and their derivatives. All of these cells come from full-term consenting women who donate their afterbirth, after pregnancy, for science. And so if you have a child, you probably recall being in the hospital and maybe cutting the umbilical cord. And prior to delivery, you may have been offered the opportunity as a family to donate the placenta and donate the umbilical cord to quote unquote science. Well, tissue banks across the country collect that tissue, and depending on the use of the biologic, different parts of the placenta or different parts of the umbilical cord can be utilized to augment the body's natural healing ability. Now, there's a very important distinction here. When we use biologics from an umbilical cord or from a placenta, they are not healing tissue themselves. They are supporting the body's own process of repair at a cellular level. And it's really very important to understand. Uh, if a patient has chronic kidney disease or has diabetes or has lupus or multiple sclerosis, there might be this notion that, quote, stem cells can cure those diseases. I would encourage everyone to take a full step back and please tell me first how many patients on insulin have been cured of diabetes? How many
I
patients
like
on
to think of it,
steroids
if
have
I
been
might
cured?
interject. Yeah, I
Yeah.
just want to interject. I kind of tell patients this presentation, think of it as that the growth factors are those upregulating things that are in the slurry of umbilical cord tissue or amnion tissue or Wharton's jelly, all those PDGF1, PDGF2, all those different things that are cytokines, which are anti-inflammatory, are kind of like fertilizer for grass, rather than thinking of them as live cells that are incorporating somehow.
I like that. I don't use fertilizer. I usually compare it to osteoporosis. Almost everyone understands that if you have thin bones, as you age, you need calcium, magnesium, and vitamin D. And no one would call those a stem cell, right? They're supplements. But sure enough, if we don't have them, our bones will break. Well, you need calcium, magnesium, and vitamin D, and without those, your bones get soft. In kind of like your fertilizer model, there are growth factors, specifically collagen-based growth factors, in these birth tissues. Those collagen-based growth factors are no different than calcium, magnesium, and vitamin D, because as our joints start to age, we don't make and we can't consume enough collagen, especially the unique subtypes of collagen that are in our joints to be able to keep our joints healthy. Can you use the growth factor complexes that are in these birth tissues to supplement, like your fertilizer model, cartilage-based defects? You can. Will those growth factors and their influence on the body's own cytokines, the body's own interleukins, down-regulate inflammation so that the body can actually go through the cellular process of healing? They in fact can. And very similar to your fertilizer model, if you put the right fertilizer on your grass, you get beautiful grass in the summer. If you put too much or the wrong fertilizer, you burn your grass up and your grass is all brown and awful in the sun.
Here's another thought that you just triggered in my own mind. You know, if we think of stability of tissue, as we get more of a matrix of tissue, which these things are helping to establish, there's going to be a more regular pattern, a less irregular pattern, and more of a stable position of the tissue, so that you're not going to generate as much inflammation internally, because you know either the wound is healing or the tendon tissue, the synovitis is calming down. Um, if we're looking at joints, to the extent that these things can help repair joints, either by helping with decreasing synovitis or possibly helping the formation of cartilage, which is a little bit more controversial.
Well,
Yeah,
so no human cell and tissue product can be used as a drug, meaning that it can't remodel inflammation, it can't generate cartilage. But let's understand. When we're young, I think all of us would agree that we probably don't remember falling at the age of 3 or falling at the age of 4. And I'm sure we got injured at 3 or 4, but our bodies were able to heal themselves because the growth factor complexes in our own mesenchymal stem cells, which are in our blood, in our bones, and in our fat, have a lot of type 1 collagen. Well, most of our injuries when we're young are type 1 and type 3 collagen. The soft tissues in joints, the soft tissues in your shoulder rotator cuff, the soft tissues around your ankle and your feet, those are all type 1 and type 3 collagen. And so our bodies have a great ability to heal those types of injuries. However, with age, we start to break down the articular cartilage, the cartilage that surrounds the bone itself. Now, our bodies don't have the ability to regenerate type 2 cartilage. This is why, with aging and repeat injury, our joints begin to go through the radiographic process that we call osteoarthritis. Now, that process can be inflammatory or not inflammatory. The unique paradigm about biologics, in particular allogenic biologics or biologics sourced outside the body for purposes of this discussion from the umbilical cord or from the placenta, are that they don't cause inflammation. They are considered immune privileged, and that's important.
So can we say that PRP would create inflammation from our own body, an autograft, as it were?
An autograft or an autologous allograft, without question, causes inflammation. As a matter of fact, it's called a pro-inflammatory response. The mechanism of action is a little specific, but by and large, if you just think about it from a macroscopic standpoint, as we're sitting here, none of us should have a lot of blood in the synovial joint of our ankle. If we do, we've had a very bad accident. So if I were to put blood in that ankle has never seen blood, that joint. And so it's going to respond like that blood is a foreign body. And it's going to cause inflammation. And the body will work to clear the red blood cells and other things. That's going to cause inflammation. Now, conversely, if we were to apply an allogenic allograft, an allograft from, say, the umbilical cord, it does not mount an inflammatory response because it doesn't have all of those cytotoxic structures in it.
Let me ask you this. You mentioned, too, that umbilical cord in particular offers a little more wide array of different types of type 1, type 2. Well, does it have type 2 collagen? I want to make sure that
it does. So the umbilical cord tissue, actually, the highest concentration by histologic weight in the umbilical cord is type 1 collagen, type 3 collagen, and hyaluronic acid. There's actually much more hyaluronic acid in the umbilical cord than there is in amniotic fluid. And amniotic fluid is been used for years and years, primarily because of the hyaluronic acid in it. But I digress. So Wharton's jelly primarily is type 1 collagen, type 3 collagen, and hyaluronic acid, but it also does contain type 2 collagen as well as type 5, 7, and 9. So it's really very robust as far as a tissue is concerned.
And so without getting too much into the devil of the details of like amnio versus umbilical, let me ask you this, because some people, they're more familiar with placenta tissue. Maybe for whatever reason, the major biologics that were out there were set up more for that model. I know MiMedx was a big company for a while that was
massive company.
Yeah, primarily advocating placenta mostly. I'm not saying they didn't do any umbilical.
Well, and so I think it's different strokes for different folks, right? Placental-based tissues are approved by the FDA, and they're actually covered by Medicare currently. If you use them in a dehydrated format, meaning you take a piece of placental tissue, it's dehydrated.
We're talking for wounds, just to be clear.
We're talking for wound care.
Yeah.
You can use it as a barrier, you can use it as a cover, or you can use it to support the wound environment. Now, none of those are claims. You're not claiming to heal a wound. You're not claiming to accelerate healing. And some companies like MiMedx did make claims. And because they made claims, specifically claims that something that should only be a barrier, a covering, or something that should support the wound environment could actually encourage wound healing and speed up wound healing, that's imparting a biologic activity on something that should essentially just be a tissue transplant. If I rupture my ACL and I harvest a piece of tissue from a pig, that piece of tissue should perform in the pig the same way it would have performed in my knee as the ACL, and so that is considered an allograft. It is taking one piece of tissue from another part of the body, same body or outside the body, where it will match the same structural function in the donor. Well, in baby, the placenta acts as a barrier or a covering, right? And so this is how and why the FDA approves it for wounds, because it acts as a barrier or covering so that you don't get the wound infected, you don't get biofilm. And if in the process the wound heals and heals fast, so much the better. Now, the literature for kind of wound healing, diabetic foot ulcers, vascular insufficiency ulcers, pressure ulcers, the literature is replete with wonderful clinical observational studies demonstrating that placental tissue grafts do a wonderful job at supporting wound health and ultimately closing wounds quickly, right? But we still can't make claims. The umbilical cord tissue wasn't used for wound healing. There's a simple reason. The placental tissues are huge, right? The umbilical cord is only typically 28 centimeters. There's not a whole lot of tissue there to make these very large grafts. I mean, patients can have hundreds of centimeters of wounds if they have burns, or if they've been on bed rest and gotten pressure sores after a spinal cord injury or a long surgery. There's just not enough umbilical cord tissue in the world to make these really large sheets of tissue as barriers or covering. And so
Dr. Martin, let me just piggyback, because a lot of people are interested in some of the applications for pain, um, tendon issues, plantar fasciitis, garden variety things that a lot of orthopedic and podiatrists will see in their office. Why is it that we have some studies out there that are RCTs, but we don't have a lot? Some are just more observational or case series. Why have companies not embraced more research? I know that when I visited Dr. Scheffler Singh several years ago, that was right after the shakeup that happened with mimetics, and the FDA was pretty much mandating the labs and companies to do more robust research to in both in the wound space, and we've seen that with things, whether it be human or cod like Kerecis. Have been
sure.
more robust RCTs with some of these, especially to get indications for insurance coverage. But not only that, but just to be able to make claims, which is why companies have backed off making specific claims. Why are we not seeing more RCTs and as you would with other kinds of medical technologies?
So the field of biologics is actually set completely apart by the FDA in a regulatory subsection called 361. And it is completely different than regulatory subsection 351. Regulatory subsection 351 are for drugs, things that would treat tendonitis, things that would treat plantar fasciitis, right? Those drugs have specific indications, postherpetic neuralgia for gabapentin, or, myofascial back pain for Lyrica, right? There are no FDA-approved indications for human cell and tissue products. Now, this includes PRP, stromal fat, bone marrow aspirate concentrate, as well as all allogenic biologics. There are no FDA-approved indications. Even a skin substitute, there's no indication of using it to treat wounds. It can be applied as a barrier or covering, but you cannot make a claim with a human cell and tissue product. Because the two regulatory frameworks are different, the burden of research is different as well. In a 351 drug, you need phase 1, phase 2, phase 3 clinical trials, randomized controlled trials. If you were to perform those trials using a human cell and tissue product, you would be doing drug studies. In manufacturers of those products who go out and do drug studies, comparative studies, randomized controlled trials, usually do them in the pursuit of making their human cell and tissue product a drug. This is why those manufacturers who have products in the 361 realm only do observational studies, meaning that under most institutional review boards, IRBs, right, all you can do is state that if I had 30 patients that had venous wounds and I placed a skin substitute on those wounds, I can show what I observed at 30, 60, 90, 120 days. Now, I can report my observations. If I have enough patients, I can even craft a p-value, and I can show whether what I observed was statistically significant. But what I cannot do is form a null hypothesis. I believe that applying a skin substitute on a venous wound is going to work faster and better than, say, applying PRP. That's a drug study. That's not something you're able to do under the regulatory framework of Section 361. Now, interestingly, and you probably don't know this, it is because of RFK Jr. that we're even still able to use 361 products, because it was advanced and moving very quickly through legislation that in about June this year, depending on which administration was in control, there were plans to get rid of all Section 361 products, including skin substitutes, and remand every manufacturer of human cell and tissue products to go through drug classification studies, hundreds of millions of dollars of studies, to show that products that have worked for over 50 years, 100 years, been used since World War II, actually are safe and effective.
I guess it still leaves me, let's say you're not trying to get the indication because you don't have a big enough population in your study, a big enough total number of patients.
Mm-hmm.
It would still be of some utility, even if you presented a study, didn't make the conclusion, but just said, here's the results with saline. Here we had a 3-arm study. Here's the results with umbilical cord. Here's the results with amnion, and had, let's say, 20 patients. So we're only talking 60 patients. So you can't make the same claims you would in a large drug trial, but you could at least present that study at a conference, and it would.
You would still have
To me, it would
still have a case controlled, comparative observational study. I think it depends on the institutional review board under which you are doing that study. If the institutional review board felt confident that using a control group, using a comparative, you were only doing that in observation, right? Meaning that, say your practice was using PRP for cartilage-based degeneration of the MTP, right? And another clinic wanted to use Wharton's jelly. An IRB could say, hey, you know what? Let's collect data from both of you. Let's have you each, apply that biologic for 30 patients so the study's powered enough. And then having observed what happens using a similar standardized tool, whether that's, a pain scale, whether that's a functional outcome scale, whether that's a quality of life scale, could you then document the observed statistical significance of one and the other and just report the findings? Yes.
And to me, that would be stronger than having a case series of 12 patients that had Wharton's jelly or umbilical cord injected for plantar
Oh, there's
fasciitis.
there's there's no
Because
question that would be stronger literature and stronger data. The, you know, it depends on the individual FDA approved IRB. If the IRB is amenable to a study like that, and I think more of them will be, and I think we're going to see more of those. It's just, it's that the investigators and usually the companies, right, are trying to straddle the fence. The investigators and the companies want to show a prospective clinical trial because prospective clinical trials are a nudge in the right direction for Medicare approval, right? And insurance approval, all right? Doing an observational comparative study, right? And just documenting what you observed doesn't get you anywhere near an indication, nor does it get you anywhere near phase 1, phase 2, or phase 3 clinical trial approval. And so that's going to be an expensive study. And because it's going to be an expensive study and you would never be able to get Medicare or insurance approval for that, um, you don't see a lot of those studies because that's probably a $200,000, maybe $300,000 study.
well,
And
I will.
PRP's been used for
Right.
50 years. Wharton's
If
jelly's
if
been used
if
for
if if
50
you
years.
if you were doing it in a more robust fashion, I mean, there's IRBs that are with residency programs that are
Oh,
operating in a
not,
shoestring
not
budget.
without question. Look, if,
Yeah.
you know, if a residency director is listening to this podcast and they want to reach out to me and they want to work collaboratively to do, a comparative observational study. I've taken 11 papers to publication in the past 3 years. I would be more than happy to talk with them and even work with their team and their residents to put something together like that. And, I think that's where this research is going to have to come from. It's going to have to come from teaching institutions that have large cadres of patients where the the research can be done in an observational way, that it's being done for the benefit of patients to try to achieve better outcomes, that there's no corporate bias, right? A residency doesn't care which product works better. They just want their patients to get better outcomes, right? And
Excellent.
and they want their residents, whether they're podiatric residents or orthopedic residents or pain management residents, to to have the best tools in their hands so that when they leave their alma mater and they go out in the community, they're getting superlative results. And when a patient goes to see a doctor from that university and they get that great result, they do the residency program proud.
Okay, last 2 minutes here. So one is a clinical point and one is a more, we touched on it earlier, and then we'll wrap it up. You mentioned potential cytotoxicity with lidocaine in one of the webinars that I attended that you did recently.
Yep.
Are we talking about, let's say we're injecting into the heel? Are you of mind that you want to do a more proximal block and not even put lidocaine in like a ring fashion anywhere near the syringe injection that you're putting into the target area of tissue that you're trying to heal?
I am exactly that. I would do a peripheral block. And, there's literature back to the 90s that demonstrates that lidocaine is cytotoxic, immediately cytotoxic to stem cells, mesenchymal stem cells, differentiated mesenchymal stem cells. I think the greater concern is that there's also literature that demonstrates that lidocaine impairs collagenic differentiation, the body's own process of making new collagen subtypes, 1, 2, 3, up to 2 weeks after lidocaine administration. Now that's a problem, right? So not only is it immediately cytotoxic, but it impairs collagenic differentiation for up to 2 weeks after application. Those two things in my mind are completely disqualifying for
Well,
the use of lidocaine.
to your point, and I just before we started this talk today, this podcast, I had a patient that I injected 1.5 cc's of cryogenically preserved umbilical cord, and I just drew it up in the syringe and injected and figured, if you're doing a lidocaine shot, it's still going to be painful until it numbs up. So this particular patient could not tolerate it, and that was my rationale with that. Now, in an area like the spinal cord, where a millimeter could make a difference, in terms of striking a nerve or something.
Well, I think
that
lidocaine
might
there
be
is
something.
even I think lidocaine there is even more dangerous.
No,
Look,
I'm saying that maybe some form of something peripheral to the target site. So if you were able
yes.
to accomplish that.
Well, I mean, I'm an interventional pain doctor. I did tens of thousands of spine injections. We just numb the skin. We don't numb all the way down, right? Look, at the end of the day, using lidocaine is what I call a hero shot. That's all it is. It's a hero shot. It makes you feel like a hero because the patient came in with pain. You gave them a bunch of lidocaine. And when they leave, they're like, oh, Dr. Martin, you're fabulous. All my pain went away. It's completely disingenuous because now you took somebody who's been suffering for a long period of time, you dumped a bunch of lidocaine in, and when the lidocaine wears off, all their pain's going to come back. But
And
now they have in their mind,
you potentially compromised your treatment too,
without question,
especially if you put in the same syringe.
absolutely, right?
A lot of practitioners
You
are doing that.
compromised your biologic if you combine it with biologic, but more importantly, you compromised your inevitable outcome. Because there aren't any treatments that take somebody from a pain level of 8 to a pain level of 0, right? That aren't lidocaine. And lidocaine doesn't last. So now this poor patient has in their mind, well, I know what no pain feels like. And they're always going to want to try to chase that feeling of having no pain. And it's artificial. We don't get to 0 pain in somebody with a really degenerated ankle or somebody with forefoot breakdown or somebody with a really, really bad, MTP joint dislocation or deviation because they wear high heels for a living, right? So this is why I call it a hero shot. You may look like a hero, but you're not.
I appreciate that. Last question, and you've been very generous with your time. I think this is going to cast a lot of light for people that have a lot of question marks in their head. Last question is, if a lab or a company product is FDA registered, explain at what level that happens with the tissue bank, so both doctors and patients understand where that FDA registration process is, and then what the secondary distribution companies do with the product.
Sure. So if take a company like MiMedx, huge company, right? MiMedx probably has 50 different products. Do they manufacture all of those products in one lab? No. They manufacture a lot of those products in different labs, and they do contract manufacturing, like many biotechs do. They function as a physician-centric GPO. They do all the heavy lifting of coordinating tissue manufacturing with labs that are expert at manufacturing tissue. And there are labs like this all over the country. All of those labs in the United States are held to specific manufacturing guidelines. Kind of like McDonald's. A Big Mac in a McDonald's in Cleveland should look the exact same as a Big Mac made in Miami or made in Southern California, right?
You had an acronym that described that began with A, the acronym that the labs function.
Well, it's called an AATB certification. These tissue banks have AATB, or American Academy of Tissue Bank certification, that standardizes how all of these biologics should be processed in the eyes of the FDA to become FDA cleared tissues. Doesn't mean they're approved to treat disease or diagnose or cure, but it means they are FDA cleared and doctors can use them in the course of practice of medicine. Now, if a lab, say Lab A, makes a wonderful product, they comply with all the guidelines by the FDA, right? And the company that contracts them decides that they're going to make claims and say that, our tissue magically restores joint health, right? It regenerates cartilage. Now that company can fall prey to warning letters by the FDA, and whoever they're making their tissue from, the contract manufacturer's lab, can be inspected, right? To make sure that number one, that lab is following AATB certified guidelines. But number two, the FDA is going to want to find out how and why that tissue is being claimed to regenerate cartilage. And what the FDA usually does is they say, hey, tissue bank is either doing a great job or not doing a great job. Say the tissue bank did a perfect job. The tissue's perfect, no issues, everything's sterile, it's wonderful. They come to the company and they say, hey, look, your tissue's great, but you're making claims. You're making drug claims. And because you're making drug claims, your product does not fall under the regulatory subsection of 361. And so, number one, stop making claims. Number two, pull your product off the market. Or number three, do both, right? Warning letters from the FDA are a challenge to something you're doing wrong. It's kind of like a slap on the wrist, right? If you get repeated warning letters and you have not changed behavior, you have not complied with FDA guidelines, then the FDA can come in and shut you down, right?
Which it has in some cases.
Which they have in some cases. Yep. There are some bad actors out there and the FDA came in and shut them down. Livion, as an example, right? They were sourcing tissue from overseas, contaminated tissue from overseas, and using completely unregulated tissue from outside the United States and kind of mixing it in with US-based tissue and then selling that to unsuspecting doctors. And
unfortunately, as happened with ocular procedures, this is going back probably over 10 or 15 years ago.
Very good. Very good.
Yeah, there was people.
Patients suffered blindness.
Yep. Because not they started with a product that had good protocol for the use that it was designed to be used for, but then they tried to enhance it with these other things to try to perpetuate it further.
Well, Subway put yoga mat foam in their bread, right? Because bread got expensive, right? Some of these companies, they decide to cut corners to increase cost.
Yeah. Well, listen, it's been very enlightening. We look forward to hearing more, maybe down the road with you, Dr. Martin. And thanks so much for doing this.
My humble pleasure.
Yeah. Thanks so much.
Have a blessed day. Thank you, Doctor.
Yeah.